Hello friends, today we'll discuss evaluation of new onset hyperglycemia. Evaluation of new onset hyperglycemia as per Davidson. So, how we should evaluate a new onset hyperglycemia? When we get a patient of new onset hyperglycemia, we have to label the patient either he is in the group 1 or group 2. So, which group is group 1? This is the group 1, and this is the group 2. So group 2 and group 1. Group 2 patient is unwell. There will be marked symptoms of hyperglycemia. Ketone bodies may be elevated. On group 1, patient not unwell. There is mild symptoms of hyperglycemia or no symptoms of hyperglycemia. Ketone bodies not elevated. So now again I am going for look for the what are the sign symptoms of hyperglycemia. So what are the sign symptoms of hyperglycemia? Everybody of us know what are the sign symptoms of hyperglycemia. So sign symptoms of hyperglycemia. The cardinal symptoms of hyperglycemia is polyuria, that is polyuria, nocturia, then polydipsia, then tiredness, fatigue, lethargy, changes in weight, blurring of vision, pruritus, itching multiple sides of the body like genital candidiasis, balanitis. There may be nausea, headache, hyperphagia, that is the predilection for sweet food, mood change, that is the irritability, difficulty in concentration, recent mood change is a symptoms of hyperglycemia. So after that we should go again to the chart. So if the patient is in the group 2, that is this group 2, so patient is unwell, marked symptoms of hyperglycemia, ketone bodies are elevated. Here resuscitation of the patient is fast. We have to label the patient, either it is a case of diabetic ketoacidosis or hyperosmolar hyperglycemic state. So we have to label the condition, in which condition patient is in. So we have to treat accordingly as per protocol. There are some protocol for the diabetic ketoacidosis treatment. There are some protocol for the hyperosmolar hyperglycemic state treatment. So both cases treatment is adequate admission in emergency department, adequate hydration of the patient, giving intravenous or subcutaneous insulin, correction of the electrolyte imbalance, treatment of underlying infection, treatment of the associated cause. Then after resuscitation, etiology, that is the diagnosis, etiological cause of the diabetes or hyperglycemia should be checked, either it is type 1 or it is type 2. So we know for type 1 diabetes mellitus, insulin will be drug of the choice. For type 2 diabetes mellitus, dietary modification, lifestyle modification, oral agents, and insulin will be treatment. And if there is any secondary causes, the secondary causes should be corrected or treated. Now, if the patient is in this first group, we mentioned there is another group where patient having hyperglycemia, but patient is not unwell. There is no symptoms of hyperglycemia or mild symptoms of hyperglycemia, and this group mild symptoms of hyperglycemia, and this is the green group. This is a green group. So their ketone bodies are not elevated. So we have to now think it is now the cause of the diabetes. Either it is type 1 or it is type 2, or is there any secondary causes of diabetes or other causes of diabetes of hyperglycemia. So again I am going to a chart where we can, from the chart we can predict to have a probable diagnosis of type 1 and type 2. So from this chart, we can predict that the patient may be a case of type 1, may be a case of type 2 diabetes mellitus. Type 1 diabetes mellitus are usually young. Type 1 diabetes mellitus are usually, so there is two groups. Type 1 and type 2. So type 1 is usually young, less than 40 years. The presentation is sudden. Patients are usually lean and thin. There may be acute presentation like diabetic ketoacidosis. Ketone bodies may be present. Patient may present with life-threatening situation. Autoantibodies will be positive in 80 to 90% of the cases. Chronic complications are rare. Family history is usually uncommon. Some autoimmune disease like vitiligo, autoimmune thyroid disease are usually associated. On the other hand, for type 2, this group, they are usually oldest, more than 50 years of age, and their presentation are slow, like they don't present with polyuria, polydipsia, polyphagia. Rather, they present with tiredness, weakness, sometimes associated infection and complication, like diabetic retinopathy, neuropathy, nephropathy, and features of that complication. So they present with complication, and the progression and presentation is insidious diagnosis, and they are usually obese. They have a sedentary lifestyle. There may be associated hypertension or cardiovascular disease as a part of metabolic syndrome. Autoantibodies are usually negative. They present with complication in 25% of the cases. They carry a strong positive familial history of diabetes mellitus. Autoimmune diseases are rarely present in this group. So, if we know from this chart, we can very well predict a patient having type 1 or type 2 diabetes mellitus. So we can very well predict a case patient having type 1 or type 2 diabetes mellitus. So if the patient having in this group, we should evaluate the cause of the patient, cause of the hyperglycemia, or the other secondary causes like chronic pancreatitis, alcohol abuse, some other endocrine disease, liver function, strong maturity onset of the diabetes mellitus of the young. This should be also checked to find out. From here, I am going to the etiological classification of diabetes mellitus, because etiology is very important to treat a case. So we know the etiological classification of diabetes mellitus. Type 1 is immune mediated destruction of the beta cell resulting lack of the insulin. Type 2 diabetes mellitus, that is the insulin resistance due to sedentary lifestyle and lack of awareness in food intake, and with having a positive family history. And there are secondary causes like genetic defect of beta cell function, genetic defect of insulin action for like lipodystrophy, pancreatic disease, pancreatitis, pancreatectomy, neoplastic disease, cystic fibrosis, hemochromatosis, fibrocalculus, pancreatopathy. These are the pancreatic diseases which can lead to secondary diabetes mellitus. Other endocrine disease can lead to hyperglycemia, like growth hormone in acromegaly can lead to hyperglycemia. Steroid in Cushing syndrome can lead to hyperglycemia. Glucagon in glucagonoma, catecholamine in pheochromocytoma, and thyroid hormone in thyrotoxicosis. All these antagonizes the action of insulin, thereby increases blood glucose level. Some drug sometimes can also lead to increased blood glucose level, like steroid, thyroid diuretics, phenytoin. So these drugs can be a cause of diabetes mellitus. And genetic disease like Down syndrome, Klinefelter syndrome, Turner syndrome, myotonic dystrophy can be a cause of diabetes mellitus. So when you get a patient of hyperglycemia, the cause should be checked either at the time of the diagnosis if the patient is stable, or later on after stabilization or resuscitation of the patient, or if the patient is unstable. So another diagnosis is gestational diabetes mellitus, which occurs in a female patient after 20 weeks of pregnancy. That is called gestational diabetes mellitus. That is another cause, and we need to know why this is important, because treatment is different from each type. For type 1 diabetes mellitus, insulin is the drug of the choice. For type 2 diabetes mellitus, lifestyle modification, dietary modification, oral drug, then insulin is the drug of the choice. If the patient having some secondary endocrine disease, so the treatment of that disease, endocrine cause, is the treatment of the choice. If there is associated with some drugs like steroid, thyroid diuretic, or phenotonic associated with hyperglycemia, we should omit or quit, stop these drugs. And if it is associated with gestational diabetes mellitus, we know for gestational diabetes mellitus, insulin should be given. Short-acting insulin, soluble insulin is the drug of the choice. So we should treat accordingly. There is another diabetes like maturity onset of the diabetes mellitus of the young. In young patients, sometimes we get diabetes, high blood sugar, but they don't need insulin for this at the time of the diagnosis, like type 1, because their maturity, young monogenic diabetes, this diabetes runs in a family. They are very well responding to oral treatment. Sometimes they don't require any treatment, like maturity onset diabetes mellitus of the young type 2, where there is a mutation of the GCK, and here we get the fasting blood glucose level is always high, but hemoglobin A1C and postprandial glucose and microvascular complication are rare. So they don't require any treatment. And there are some other types which require sulfonylurea, rather insulin requires at the later stage of the disease. But there are some bad conditions like HNF1 beta mutation, which are associated with renal cyst, and they can lead to renal failure. So the maturity onset of the diabetes mellitus is another condition which is better than type 1 diabetes mellitus sometimes. So this is how we can evaluate a patient of hyperglycemia at the bedside, and we treat the patient accordingly. So that's today's lecture. If you have any question, you can just ask your question in the comment box. Thanks for patience hearing.